morning, everybody. My name is Ruben Niesvizky. Some of you don't know me. I've been doing multiple myeloma since the early time of the 90s. And so that's the only thing I do. I do it for breakfast, for lunch, for dinner. and sometimes I have even dreams about it. I have to thank the organizers for giving me the privilege to speak to patients. It's a very rare occasion that we can actually spend long time to explain the ins and the outs of the disease, as clinics usually are hectic, are busy, and interrupted. And we strive to do that in support groups, and I don't think there is enough support groups around. So any efforts to try to connect with patients are certainly most welcome. I was asked to speak about new biological insights, and I was asked also not to put it on Myeloma 101, because after all, you guys are all myeloma experts. So it is, I think I will try to make it a little bit more sophisticated than that, but if in any given time you want me to stop or re-explain, do not hesitate to raise your hand and ask the question. There is no dumb questions here. We are all here to learn. We are here to learn from you. You are here to learn from us. I have to show my disclosures. And the first question I have is, why do I have to study myeloma? Myeloma has been a fascinating disease. In fact, I never wanted to be a myeloma doctor. I wanted to be a leukemia doctor when I started my training. And I think most of the myeloma doctors wanted to be leukemia doctors. And it was just out of accident that I fell into taking care of myeloma. And I learned that myeloma has become a disease model in understanding the biology of the disease and has multiple applications for oncology, for hematology, for cellular biology. There is no good myeloma doctor that is not a good internist, so you have to be an excellent internist. You have to know your orthopedics, your bone metabolism. So I am reassuring you that all your myeloma doctors are very well trained and very good doctors. The first tumor marker ever described in cancer, say tumor marker, something that you can measure in the blood that goes up and goes down, and you can actually measure the activity of the disease. You've heard it in prostate or in other diseases. The first one was in multiple myeloma and gave the Nobel Prize to Ernie Tiselius when actually his first paper was rejected. The monoclonal antibodies that we use now with the technology hybridoma and all the monoclonal antibodies that we use now to treat myeloma came from a myeloma cell line that was able to be modified to make monoclonal antibodies, and that also gave a Nobel Prize. In cancer, in treatments of we learn about dose response curve, for instance, and when the higher the dose, the better is the response. That's a concept that myeloma is a specific model for that. The first randomized trial, I'll speak to you about it in a second, came from myeloma. And more recently, all the discovery of the proteasome inhibitors and all that cascade of cellular biology also gave rise to a Nobel Prize there recently. So there's many reasons why we should focus on multiple myeloma. But most of all, we study multiple myeloma for you, because our goal is to try to cure this disease. Myeloma has been around for a long time. As you see here, there is Egyptian mummies with evidence of the lytic lesions in the skull that many of the patients have. So it's not a disease of the modernity. It's been around. And the first description came with this patient who's actually a 45-year-old woman who had a condition that was progressive, characterized by severe bone pain, multiple fractures, and then developing of fluid retention, some condition that we call as anasarca, when you collect too much fluids because of renal dysfunction. Unfortunately, that patient died, and upon the autopsy, they were seeing that the bones were actually replaced by a situation, by a red marrow condition. They didn't know what it was, but they call it softening of the bones. During those days, the treatments were bloodletting, leeches, and things like that. That certainly did not work. But that opened the discovery in multiple myeloma. So as you well know, myeloma is characterized by an excessive proliferation of plasma cells. The plasma cells are depicted in that picture. And as we will see now, these are the end product of a preliminary cell or a precursor cell, which is a B lymphocyte, which is involved in the development of antibodies. And as such, these cells carry the potential of produce antibodies, and they're producing an immunoglobulin, which is the antibody, and that's actually what we measure as the M protein, as the tumor marker that reflects, in general, the amount of disease that somebody has. When the disease advances, causes several end organ damage, what we call the CRAB criteria, C for calcium, where the calcium goes up in the bloodstream after the bone destruction is such that there's no more enough in the bone that goes into the bloodstream, and that can cause several symptoms. Renal disease, as these immunoglobulins can damage the kidney. Anemia, of course, as the bone marrow is dysfunctional and cannot produce red cells. Remind you, it's not a nutritional anemia, it's a different type of anemia. And the frequency of infection as a result of the lack of proper immunoglobulins, as there is an excess of the immunoglobulins produced by the malignant clones. So let me tell you about a new treatment described by Olwal and collaborators, or a patient with multiple myeloma who had a reduction by the use of this new treatment. Was a reduction on the serum globulin concentration from 5.9 to 2.2. That was the marker. And there was an increase on the hemoglobin. The red cells went up from 60% to 80%. And there was reduction of the proteinuria, the reduction on the protein in the urine. And the bone marrow plasma cells reduced to 0% when treated with this drug called urethane. So anybody would like to receive this treatment? Raise your hand who wants to receive this treatment. I'm glad that none of you, because that's the treatment in 1947, and it persisted as a treatment from 1947 to 1962, in which Jim Holland, very renowned hematologist, oncologist from New York, who recently died a couple of weeks ago, did a control study. This is the first randomized trial that I was telling you about, in which he picked 83 patients, and they were treated with urethane or the placebo. And the placebo was urethane plus Coca-Cola. So there was no difference between the treatment groups, and in fact, the urethane treatment patients died earlier. So what's the bottom line of this slide? The bottom line of this slide is that every step that we do to try to offer you treatment has to be based on science, and it's clear there is a clear methodology for us to continue treatment based on clinical trials, and that's why we insist so much on clinical trials. So to move to the subject I was asked to talk about is the biological insights, and such I want to tell you that the myeloma cell is a B cell, and the normal function of a B cell is to produce antibodies. The way that it works is that that cell will recognize the antigen, call it the antigen, a virus, a bacteria, any type of foreign element. The cell will recognize it as abnormal with a receptor that is similar to the antibody, and the cell will start proliferating in all identical cells. So one cell starts giving birth to a clone, and that's why we call it monoclonal, because for each antigen, for each bacteria, for each virus, there is going to be a family of cells, a clone, that will proliferate, and in turn will divide and produce cells that are capable of producing the antibodies. These antibodies already have the specificity against the original insult, which was the virus or the bacteria. So it's as specific as a key and a lock. That antibody should destroy the antigen and should be augmented in such a way that the plasma cell is now producing the antibody and will multiply until it can kill the original antigen. Some of these cells, the IPCs that you cell, will travel into the bone marrow and stay attached to the walls of the bone marrow, producing a constant amount of those antibodies, so you can always respond faster when you get re-exposed, and that's the principle of vaccination. If you get a flu shot, when you get you educate your immune system in this way, you will always have the ability to attack the real infection when you get exposed to. So in multiple myeloma, however, this does not happen. The plasma cell once produced this antibody, and the population that produced the antibody and did not go to the bone will to the bone marrow to sit there and produce the antibodies will eventually die. And that's what we call apoptosis. It's a programmed cell death that will allow the cells to recycle. So that's the normal cycle of the plasma cells and the B cells. In myeloma, unfortunately, that apoptotic death does not occur. The cells do not die and start proliferating in all identical cells, producing a single antibody with the same similar characteristics. So in general, the higher amount of cells, the larger amount is going to be the protein. I say in general, but because we all have patients that does not necessarily reflect. But in general, that's the principle. If you see the cell in the top right has a little different shade, and the different shade is because there's some subclonal differences between cell and cell, talking about heterogeneity, and that we have learned lately. In the beginning, we all thought that this was a more uniform condition, that all the cells have exactly the same characteristics. These cells survive because they can adhere to the bone, because they have a dysregulation of elements in the cells, such as BCL2, NF-kappa B, that permits the cells to grow and multiply, and growth factors or cytokines that permit that growth as they attach to the bone, such as IL-6. So we can actually sometimes measure IL-6, and the higher the level of IL-6, the worse is the prognosis. We have a Pursman IL-6 that your doctors can measure all the time. That's called C-reactive protein, very easy to measure, and usually reflects what the IL-6 is. The cells in this progenitor phase have this CD20 marker. The CD20 marker is the marker usually that we use for myeloma, and actually there is a monoclonal antibody against those cells. It's actually usually used in other malignancies. As the cells mature, they start expressing CD38, and you have heard about the relevance of CD38 lately because of therapeutics against it, and more mature cells will produce the CD38. So this process, as I was saying, it is heterogeneous. You see the different in the subclones, and although there is the belief that it's an evolutionary process, but it doesn't necessarily have to be linear. It has to be full of ramifications, and you can have different subclones from the very beginning of the growth of the cells or within the evolutions. As the cells get exposed to treatment in first line, second line, and third line, you can gather more mutations. Within the second thing I was asked to discuss is the chromosomes. And when we talk about chromosomes, when we talk about chromosomes, we want to talk about not the somatic or your own chromosomes, the ones that you inherited or the ones that you give to your progeny, but the ones that the cell has. You have a question?
Yeah. The change from CD20 to CD38 to CD138, is that a maturity of the myeloma disease?
Of the cells, yeah. So the immature cells express a protein that is in the surface, that is CD20. As those cells mature, they lose that CD20, which is in the surface, and the CD38 appears. And then the CD38 remains, and the CD138 appears. So there are traits that the cells acquire and lose as they mature.
And we're going to be taking, we have 2 extended question and answer periods after each round of lectures.
So we will continue talking about that. But I was telling you that the chromosomes of the cells that we're talking about are of the myeloma cells. We're not talking about the chromosomes that you inherited. There's 2 pathways of abnormalities in the myeloma, and usually is when you have multiple copies of chromosomes. Typically, in multiple myeloma, you have multiple copies of the odd number chromosomes. Remember, we all have 46 chromosomes, and we number them from big to small, from 1, 2, 3, and so forth. Every odd chromosome can be triplicated, quadruplicated, so you get 3, 5, 7, and that's what we call the hyperdiploid. The non-hyperdiploid are those who have less than 48 or more than 75, and those usually have bad prognosis. Fortunately, that occurs in less than 20% of the patients. In addition to that abnormality, you can see that the immunoglobulin gene that is involved in the production of the antibodies can get disrupted and get attached to another piece of chromosome that can make a new protein or an excess of proteins that will drive the cells into more division, more aggressiveness, and even be able to travel outside of the bone marrow. Here are a list of all the partners of chromosome 14 that can lead to different translocations and can deal for the cells to become abnormal. The typical one that we have here, where a protein called cyclin D gets upregulated as a result of the chromosome 11 attached to the chromosome 14, the 11-14. But as such, you can have 6-14, 12-14, or you can have 16-14, 20-14, or 8-14 in the lesser amount of the patients, or the 4-14. The MAF group and the MMZ group are those who give you the poor risk, and those patients have been tagged to different type of treatments, different approaches, whereas the more traditional myeloma, the more frequent, is the 11-14, is the cyclin D group, as you see here. So if you put in summary, most of the translocations associated with the immunoglobulin gene, the chromosome 14, are the most frequent, and then there is other ones that we cannot find any partner there. You tell me when I'm out of time. Talking more about these translocations. So you have the 16 and 20 pairing with the chromosome 14, or the 4 or mix of those, or the 1114. Either way, they all regulate enzymes inside the cell that are combined with other coenzymes that will drive the cells to division. It is well understood that interrupting some of these may lead to interruption of the cell division. So there is a lot of therapeutic agents that are being developed to try to block that process. So more about the chromosome analysis. It can be used by taking up pictures where the cells are dividing. We call them conventional cytogenetics. That's the taking the picture of the patient or of the cells when you catch them in the act. But the FISH allows us to look at them at all the time, and so it's more and more sensitive. And has allowed us to divide the cells in the non-hyperdiploid, on the hyperdiploids, and the IGH translocations that I just mentioned. But the field is moving forward, and now we can actually look at the genes that are activated, and they can give us an idea of how many myelomas are, depending on what protein product and what RNA product are the result of those disruptions of chromosomes. Gene expression profiling has been done and has been able to detect, at least as you see here, 9 different types of myeloma. And we're trying to correlative in general with clinical features. So we can say a patient who has more tendency to develop bone disease has a different gene expression profile signature. Some patients who have very high risk who have a different type of gene expression profiling. And there are several platforms that we can actually take from the bone marrow and measure those genes. They're commercially available, and there's other ones being further developed. In general, they all give the same information, just telling us that myeloma is really an heterogeneous disease, that we don't have only one myeloma, that we have about 9 myelomas, and that we have to learn to correlate with clinically and then maybe even offer different treatments, hopefully. Still, we are not able to define treatments. But the field is still moving fast forward, and now we can actually do wide genome analysis and see how many mutations the patients have, and possibly we can identify one mutation that is actionable. And when I say actionable, we can have a drug that can actually attack that mutation. We can do more specific therapy. The challenge in myeloma is that, in general, a patient with myeloma presents with about 5,000 different mutations. So it's very hard to pinpoint one single one. And the second problem is that it's very plastic. So the gene abnormalities that we have today, they won't be within your second treatment, they won't be during your 4th treatment, and so forth. So that's the challenge that we, as investigators, have of having to be able to identify so many mutations so we can treat the patients. Maybe we will be able to detect a mutation that will capture 20% of the cells, but what about the other cells? So what we have been trying to do now is trying to attack the myeloma in the cellular level, not in the genetic level. And as you see here, we have different treatments with different levels of success. The steroids that everybody hates give very good response. It's a very rapid response, but because of intolerance or because of resistance, it's also very short-lived. Then you have the alkylators, which is the traditional chemotherapy, that will give you a slower response, or unless you do it in a very high dose, as you see here, the high dose therapy. But eventually, the cells will have some resistance, and the disease will relapse. So the goals of the newer therapies is to push that curve below the limit of detection, and hopefully reach the cure. So for that, we use a combination of all these drugs, the high dose therapy, the alkylators, the dexamethasone, either in combination or in sequential form, to try to reach that below detection state. The below detection state is what we call the MRD negative. And the MRD negative can be now identified by several criteria. Not every MRD is the same. So you can have sustained MRD, you can have MRD by negative by flow cytometry, which is a technique that it will identify up to 100,000 to maybe 10,000 cells in a given time. In the best hands, with the best technology. The sequencing that I was telling you, the wide genome sequencing can even give us more information and maybe be used for minimal residual disease. And that's the next step. We can almost identify up to 10,000 or anything between 100,000 to 10,000 cells. And we have to add, even in the case that we have a complete negative bone marrow without evidence of residual disease, we always have, we should not forget that the bones can still have spots with myeloma. So we're trying also to develop imaging minimal residual disease. So it gets complex to define a real complete remission. But what we do believe in that the patient who achieves a complete remission can reach the cure. And when we say complete remission, anything below the detection level with the best technology. If we can keep it down to less than 10 to the 4 and maintain it, I think we can be able to reach that level of cure. So this is what the iceberg slides. You can see the amount of disease that you can measure with the SPEP or when you have your M protein. But when you have no more M protein, you should think that there is still some disease left behind, and the technology in terms of detection is moving better to look at it closer at lower levels, and hence our treatment will also improve to get to that level. So my last slide is some mention. I'm not going to talk more about the treatment, but just to give you an idea that as we move to the newer therapeutics, the combination of immunomodulators with antibodies such as elotuzumab can engage the normal occurring killer cells, natural killer cells or T cells, to try to kill the myeloma cells. And in case of the CD38 that I told you about, the antibody anti-CD38, and there are several in development. The one that is already approved, called daratumumab, can, in combination with the proteasome inhibitors and the immunomodulators, have multiple actions to try to destroy the myeloma cell. And in fact, now we can use these antibodies in the relapse setting or even in the frontline setting, offering the patients complete remissions that were unheard of before. So it is very, the picture is pretty optimistic in my point of view. So let's go back to the history and where are we right now. From the 50s to the 60s, I told you urethane, and then steroids, radiation, and methylprednisolone. And then from the 90s, we already had the stem cell transplant. In the 21st century, the immunomodulators, the proteasome inhibitors, started to show improvement, moving the disease from fatal disease to a chronic illness. And now, as we move to the newer therapeutic with so many new drugs being approved, I think we're getting closer to the cure, and we are able still to use all these treatments for our goal. We always have to remember we need to do it through clinical trials, through a lot of translational research between the bench scientists and the clinical scientists to achieve that cure. Just a word that the Myeloma Center at Weill Cornell is in close collaboration with the Myeloma Center in Colombia. We're trying to do a joint venture. These are my collaborators in the downtown, but Dr. Lynch is a close collaborator, and we're trying to join forces in putting clinical trials together as all for the benefits of myeloma and of course you. That's my last slide. Thank you for your attention.